Thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time, but please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Today's webinar, Delays in Diagnosis of Pituitary Tumors, Why They Happen and Steps to Prevent Them, is being presented by Dr. Kenneth De Los Reyes. Dr. De Los Reyes is the third child of immigrant Filipino parents. He grew up in the heart of New York City in a middle working class family where he was raised with traditional values of hard work, humility, love, and dedication. His mother, an accountant and nurse before he was born, raised her 3 children with his father, who worked 2 full-time jobs for more than 30 years. After graduating summa cum laude from the City College of New York and the NYU School of Medicine through the prestigious accelerated BSMD program at the Sophie School of Biomedical Education, Dr. De Los Reyes moved on to the Mount Sinai School of Medicine to complete his neurosurgery residency. During his elective time, he completed a Master's of Science in Clinical Research. It was at Mount Sinai where, mentored by neurosurgeons Dr. Kalmon Post and Dr. Joshua Bederson, his passion for skull base and pituitary surgery began. He decided to continue his subspecialty training under the well-renowned pituitary surgeon Dr. Edward Laws at the Brigham and Women's Hospital in Harvard Medical School for 1 year. There he focused on endoscopic skull base and pituitary surgery. He spent 1 year of subspecialized fellowship training with Dr. Harry then Loveren at the University of South Florida in Tampa General Hospital in complex cranial and skull base surgery. Dr. De Los Reyes has been practicing at the Loma Linda University Medical Center in Loma Linda, California, where he has directed the Center of Skull Base and Pituitary Surgery since 2014. Dr. De Los Reyes, thank you so much for your involvement in our webinar program. Really looking forward to your presentation. There will be a brief delay as we change presenters, and then it'll be all over to you. You should be seeing it on your end come up in a minute. Okay, I can see your screen.
All right. Okay, thank you, Tammy.
Thank you.
Well, it was a great introduction, and I really appreciate, and I'm really grateful for this opportunity to speak to everyone here at this webinar, so I hope this is helpful to all the attendees. So I have no financial conflicts or disclosures. Some of the images over the course of the presentation are graphic. They are patients that have given their consent. Many of these slides also have been added to my presentation from Dr. Ed Laws's collection. As Tammy mentioned, he's one of my mentors and a very kind friend. I'm very grateful to get his permission to provide these slides to you. So just, yeah, again, I came from New York City where I trained, and then moved to Boston for a year with Ed Laws, and then Tampa, Florida to do another fellowship in skull-based surgery, and I've now been in Loma Linda for the past 3 years. And so it's been a long road. I'm moving further and further out west. And here at Loma Linda, nestled in the mountains, in the San Bernardino Mountains, Dr. Cal Post, I want to mention my other mentors, Dr. Harry Van Loveren, Dr. Ed Laws, again, great teachers, educators, and now friends. And I could not have been where I am without their help. So just an outline of what we'll be discussing today. I always like to discuss briefly the anatomy of the pituitary gland and the anatomy surrounding it. And then we'll discuss the delay in diagnosis problem and its repercussions, management of pituitary tumors and disorders, which is very complex, and leading up to this idea that's been growing, particularly over the past 5 years, of this Pituitary Center of Excellence. And then I'll just briefly discuss some of my experience in pituitary surgery. And so starting off with the anatomy, the pituitary gland is really the master gland of the human body, and it controls many important activities that includes growth, sexual maturation, reproduction, metabolism, stress response, and fluid balance, among other activities. The pituitary gland, the development of it comes from really 2 layers. One is neural, and the other is actually oral. And so neural tissue and oral tissue, they join and eventually create the pituitary gland here. And the neural portion is the posterior pituitary gland, and the oral portion becomes the anterior pituitary gland. So here's an illustration of just demonstrating how small the pituitary gland really is. It is the size of a peanut, laying at the base of the brain, connected by the pituitary stalk. And again, this is the anterior hypophysis or anterior pituitary gland, which is oral tissue, and then neural tissue, the posterior pituitary gland. This is a cadaveric dissection from Dr. Al Roten. Very beautiful dissections with vessels injected with silicone. And again, this is a lateral view. And so this is the front, and this is the back. And just taking a slice through half of this cadaveric brain. And again, here's the pituitary gland sitting here, the pituitary stalk, and it's connected to the hypothalamus in this region, and the optic nerve. So these next few slides will just demonstrate the complexity of the anatomy and the very important neurovascular structures that are surrounding the gland. So here's a frontal view. Here's the pituitary gland. And here's the carotid artery on either side. This is a superior view here, and showing the pituitary stalk and the relationship of the posterior gland and the anterior gland. The posterior gland is much smaller. This actually is the center for controlling fluid balance. And again, just very nice dissections of the anatomy here. The pituitary gland sitting here, the pituitary stalk again. And you just see how the intimate relationship of the optic nerves, which lie just above the pituitary. The carotid arteries on either side, and very small vessels supplying the pituitary stalk and the pituitary gland from the carotid artery. Just going to fast forward on a couple of slides here. And this is a view demonstrating the optic chiasm, which is where the 2 optic nerves join. And just above it, superior to it, we have the 3rd ventricle and the ventricles. So here are the frontal horns of the ventricles, here and here. And sometimes pituitary tumors that enlarge can block fluid flow in the ventricles and cause hydrocephalus and increased pressure in the brain. So this is again, just to describe the complexity of the anatomy here. Again, this is the lateral view, pituitary gland here, the pituitary stalk, and the chiasm laying above. And this is all very variable among people. The chiasm's relationship to the pituitary gland can sometimes the chiasm can lay in front of the pituitary gland. The chiasm here can lay right above the pituitary gland, and sometimes the chiasm is post-fixed and lays posterior behind the actual gland. All very, very important relationships when we're describing approaches, if ever these tumors require surgery. Understanding that anatomy is critical. Here's a cartoon illustration demonstrating, again, here's the pituitary gland, and on either side you have the carotid artery, just above the optic chiasm, the optic nerves. And then on the side of the carotid arteries, on either side, are these very important cranial nerves that control eye movement. They're all numbered. 3, 4, and 6 are important for eye movement, and cranial nerve V1 and V2 control sensation of the face. So any of these structures can be put at risk by a tumor that's enlarging, but are also at risk if surgery is being performed. Now, even the sinuses, which is the approach we take to get to a pituitary tumor, these are complex. The anatomy of them are not so simple, and so this just demonstrates the different sinuses in our face. There's the maxillary sinus on the side, which is deep to the cheek, the ethmoid sinuses, which are on the side of our eyes, and the frontal sinus, which is behind the forehead. All air spaces that allow us to get into the area of the pituitary gland, tumors that reside here. And here's the sphenoid sinus, which is that air cavity that is lying generally just below the sella, which is where the pituitary gland sits. And that's why we call this a transsphenoidal approach, through the nose, through the sphenoid, transsphenoidal, to get to those tumors. And these are much of the same cadaveric dissections. We use X-ray as well. In the past, we would use X-ray in the operating room to help us identify this sella. Again, this is a lateral view. So this is the front of the patient. This is the back of the head. And this is a magnified view of the sella turcica, or Turkish saddle, where our normal pituitary gland sits. So we want to see this, and we would use these X-rays to help us identify this structure in order to safely get to tumors here. And I will pass this screen here. Now this color illustration here is just a picture of the sphenoid sinus, that transsphenoidal approach. We have to get from the nose into this area here to get to the pituitary, but even that can be variable. Even this is a more normal airspace filled with air. It's pneumatized, they say, and there's a precellar and a conchal sphenoid sinus. These are sinuses that are not as pneumatized, not as air-filled, more bony, which makes it more complex. Again, different factors that we all play into how we decide and whether we decide to do surgery or not. So here are views of an endoscopic approach in a live patient in an article by an Italian group. And this is the view of the inside the right nostril. This is the nasal septum. This here is the middle turbinate, which is a nasal valve allowing for mucus drainage within the nasal cavity. And as we get deeper and deeper in, this middle turbinate we push off to the side. And here's again midline. This is the center, your septum, that sometimes can be deviated. And as we go deeper, we find this small hole. And this is a surgical approach. to get into the sphenoid sinus. Here we're resecting the middle turbinate, which we sometimes do in order to widen the space so that we can get into this cavity and make this cavity. This is actually inside the sphenoid sinus now, so we've gone now transsphenoidal to get to the back wall of this sinus, which is the cellar floor. So here it is, this is the cellar floor. Now we're right within the sphenoid sinus cavity. This is the cellar floor, and these impressions, these are all bony impressions that highlight the structures underlying it, which is the optic nerves here, carotid arteries here, and this cellar floor. Above that, once the bone is removed, would be the pituitary gland. And here is bone removed now, and so this was the cellar floor, that Turkish saddle, that bone that's removed. And what we're seeing here is dura, which is the membrane that surrounds the brain and protects the brain and pituitary gland. And again, these are optic nerves on either side, and the carotid arteries here. Deeper still, after we open up the dura, the membrane that surrounds the pituitary gland and the frontal lobe, once we open up that dura, we can uncover the anatomy here. This is the pituitary stalk. The pituitary gland is off the screen here. This is the optic nerve, and the optic nerve on the left. This is the chiasm, the junction of the two optic nerves. And all these small little arteries here from the carotid artery supplying the stalk, the chiasm, and here are other important arteries above the optic chiasm. Here's really magnified views of even more anatomy. The basilar artery, the hypothalamus. And so these endoscopic views have allowed a lot of improvements in visualization and illumination, helping make surgery safer. So that's just a brief overview of the anatomy. Again, just understanding that complexity of the anatomy that takes time to understand and a lot of training. So then we'll move forward with the pituitary adenomas and this idea of delay in diagnosis. So pituitary adenomas are actually fairly common. This has been looked at in different studies. Azat et al. Found that the overall prevalence, the numbers of patients and people with pituitary adenomas is as high as 16.7%. So that's about 1 in 6 individuals. 14% in autopsy studies, and 22.5% in some radiological studies. So on average, about 1 in 6 individuals have pituitary adenomas. Now, most often they're asymptomatic, they're tiny, they're found incidentally, and don't require any management, but just it's kind of remarkable how common they actually are. These are different studies, mostly in Europe, again, just demonstrating the prevalence and the incidence of pituitary adenomas being a lot higher than I think most people would think. So again, around 1 in 6 people have one. Here's one of the slides from Dr. Laws and his presentations that he provides. These pituitary adenomas, where do they come from? What's the cytogenesis of these tumors? So what happens is, well, first off, the pituitary adenomas are mostly random. And statistically, the pituitary gland, just like much glandular tissue in the body, your thyroid gland, your adrenal glands, your parathyroid glands, these are very high volume factories of cells with high turnover rates, where cells die and cells are created and regenerated. And in such a gland and such a factory of cells, the likelihood of a mutation in one of those cells is much higher than in a dormant organ in your body that doesn't produce any cells. So the pituitary gland is a common source. Now the pituitary cells, they come from this pluripotent precursor cell, which then divides into a number of lines of cells. So we have the acidophil stem cell, which then leads to mammosomatotraps and the growth hormone and prolactin cells. And these lines can produce tumors, growth hormone adenomas or prolactinomas. There's the corticotroph stem cell. That line, it produces ACTH producing cells in the pituitary gland and can lead to ACTH adenomas and Cushing's disease. And then we have the glycoprotein stem cells, which produce the cells that create FSH-LH, thyroid stimulating hormone. And then there's this null cell stem cell. There are some cells in the pituitary gland that really don't produce anything, but then they can mutate and become a null cell adenoma or non-secreting pituitary adenoma. And this is an autopsy figure of what an adenoma can look like. Here's on the right side of this pituitary gland, this large adenoma, and here's the normal pituitary gland, and here's the pituitary stalk. This picture is looking all too familiar. Here's one that's much larger. It's another cadaveric autopsy dissection of a large mass, and this is actually infiltrating and going into these fluid spaces, the ventricles, into the third ventricle. So they can be very small, they can be very large. And so what are the common complaints with those with pituitary tumors? So it really ranges from depression, apathy, sleep disorders, memory loss, other mood disorders, anger, agitation, anxiety, weight gain, fluid retention, sexual dysfunction, infertility, fatigue and weakness, visual loss, emotional lability, headache. And what makes pituitary tumor diagnosis so difficult is because all these things here, all these complaints can have nothing to do with pituitary tumors. So you have to start looking at what are the red flags that may point in the direction of this being a pituitary tumor. So, sources of psychological problems. Why are there psychological complaints with those with pituitary tumors? One is because of the distortion of body image. There are certain conditions with secreting pituitary tumors, those tumors that overproduce hormones, like growth hormone and acromegaly, which can lead to distortion of the body, enlargement of your hands, disfigurement of the face, and then Cushing's disease, overproduction of ACTH hormone, that can lead to obesity, rounded, your face becoming rounded and very red, and weight gain. So that can lead to psychological problems. Those with diminished sexual hormones because of a pituitary tumor, they can have a lack of sex hormones and loss of their sexual identity. There's anxiety from visual loss and other associated illnesses that these pituitary conditions can create. And the fatigue and weakness that can be very depressing for patients. So as you can see, a lot of the complaints can again be completely unrelated to pituitary tumors, so the diagnosis can be challenging. What's at stake, though, is the impact that a delay in diagnosis can have. So take, for example, acromegaly. Again, this is a pituitary tumor overproducing growth hormone that begins to circulate in your body, and the downside effects of growth hormone can lead to organ failure, so enlargement of your heart, cardiomegaly, enlargement of your liver and liver failure, hepatomegaly, kidney failure because of enlargement of your kidneys, enlarged colon. So many of your organs enlarge with acromegaly, as well as soft tissue. So you have enlargement of your hands, your feet, facial features, facial deformation. You get swelling of your tongue. You have enlargement of the soft tissues in the back of your throat. These are all things that occur in acromegaly. This condition reduces life expectancy up to 10 years. It is on average, a delay of this diagnosis can be up to 6 to 8 years. And that hasn't changed much in the last couple of decades. And why is that? What is that delay from? Some of these changes are very subtle. You know, they don't occur suddenly. They do occur over several years, and so many people don't even notice it. Oftentimes, the way it's detected is picked up as someone's friend or family member that hasn't seen that person in a few years or decades, and suddenly they notice the dramatic change, which was not picked up by those that have seen them day to day. There's also some medical unawareness of what acromegaly really is. It's not just gigantism and someone being very tall. That's actually far from it. The diagnosis is difficult too because of the laboratory testing that can be challenging. And there's the delay diagnosis has a significant clinical impact. Tumor grows, and tumors can grow and become macroadenomas and can create problems with vision. Some of the downside effects, the heart enlargement and liver enlargement, once it happens, those problems can be irreversible. Enlargement of the colon and increased number of colon polyps can occur in acromegaly and can lead to colon cancer too, and these are irreversible if not detected earlier. Now, factors associated with delayed pituitary adenoma diagnosis in patients with visual loss. This was a paper by, Dr. Agi, UCSF, and there's a group in Texas and UT Southwestern that looked at what are these factors that led to delay in this diagnosis. So visual symptoms, they are the most common complaint for those patients with non-functioning adenomas or non-secreting adenomas. And the visual loss is often not sudden, it's also gradual, which can sometimes make diagnosis challenging. It can occur for many months, it can occur for many years. In this study, they looked at 75 patients with their non-functioning or non-secreting adenomas removed, and the vision symptoms had occurred a median of 6.5 months before surgery. And that ranged from 1 month to 15 years. And what did they find? They found that the age at symptom onset was the only factor in their univariate and multivariate analysis that predicted a longer duration of visual symptoms. So older patients were the ones that had their tumors longer before detection. It took a longer time for them to detect. And in this graph here, this box and whisker graph, you can see here on this side is duration of visual symptoms in months, and here is they divided up among age and white and non-white groups. And so the white 20s and 30s group, the duration of their visual symptoms was the shortest before surgery. And the older non-white group, 60s to 70s age group, it was a longer duration. They had many more months of this visual loss before they detected their tumor. And again, they only found that age was the only variable, the most significant variable prolonging symptom duration before surgery. And why is that? Why is age the issue? They found, and they postulated that as we get older, there's this general acceptance by older patients that declining vision is natural. It's part of the aging process. What's often challenging too as we get older is that we get other ophthalmologic conditions like glaucoma, macular degeneration, cataracts, diabetic retinopathy. These are conditions that are very common in older patients, far more common than pituitary tumors. So those are probably looked at first before, and rightfully so, before detecting a pituitary tumor. And then there's this particular delay, like I mentioned, in non-white elderly patients, and that's a little bit unclear why that is. Is that a educational problem? Is it a language barrier? Is it, it's a little bit unclear. Is it an access to healthcare issue? And so aside from looking at the age being the major factor that was associated with longer duration of symptoms, they also looked at what were factors that were connected with normalization of vision. And they found that your duration of symptoms predicted how well your vision was going to be. And so there was a linear correlation that they identified between the duration of symptoms and irreparable visual loss. So in other words, the longer you had visual symptoms, the harder it was to reverse that problem, to repair that visual loss. So pituitary disease management and the multidisciplinary idea, this comes about now. I mean, we looked at the anatomy and seeing how complex it is. We looked at this delay in diagnosis idea and the impact that it can have on someone's vision or overall health and acromegaly or Cushing's. Now, the management is also extremely complex. The diagnosis is complex. The management is challenging. So this was a study done looking at the relationship of in patients that had pituitary surgery, transfemoidal surgery, the relationship of mortality and volume. And it's clear that there is a relationship where if there's a smaller volume of transfemoidal surgeries done at a hospital, they have a higher mortality rate compared to those that have a larger volume where there are transfemoidal surgeries done at a certain hospital, and their mortality rate is lower. Same thing goes for surgeons. So a surgeon that does one transfemoidal pituitary surgery in any given year has a higher mortality rate than surgeons that have a higher volume and do these more often, do the transfemoidal surgeries often. Their mortality rate is far lower. And the same thing goes for, aside from mortality, but you look at discharge home. If in a certain hospital, if they don't do it as often, or their resources are more limited to do transfemoidal pituitary surgery, their discharge of their patients anywhere other than home is far higher than in hospitals and in surgeons that do them in larger volumes, that do these transfemoidal surgeries often. The higher the volume of cases that are seen by a hospital or by a surgeon, the more often those patients will go home, which is a goal, rather than being disabled into a rehab facility, for example. So volume and experience does make a difference. The goals of treatment of pituitary adenomas, sorry about the noise there, I'm going to fast forward here. So these are when we look at just as a whole pituitary adenomas. What are our goals? So goals include relief of mass effect, the pressure buildup from an enlarging tumor on the optic nerves most often. We want to normalize the hormonal hypersecretion. So that's tumors that are oversecreting growth hormone or ACTH creating Cushing's. We want to normalize that, take out the tumor so that overproduction is gone. We want to preserve the pituitary gland, so we try not to damage the pituitary gland and restore pituitary function if possible. If a tumor has crushed or compressed the pituitary gland and with reduction of hormones, we want to try to restore that by potentially releasing the pressure off of the gland. We want to prevent recurrence of this tumor, so we always try to do as extensive as a resection as safely possible, and then obtaining tissue for diagnosis, pathologic, and even scientific study. What are the strategies of treatment? So very complex, it's a very comprehensive strategy. We often try to find first medical treatment, right? So if someone's tumor is causing their pituitary gland to malfunction and with reduction of hormones, hormone replacement therapy is critical. There are different medical treatments for certain disorders like a prolactinoma. Dopamine agonists can be used. These are other medications that can be first line used for Cushing's disease and acromegaly. Then we look at the surgical strategy for treatment, which oftentimes, if it's safe, is the first line treatment for Cushing's disease, acromegaly, and so we call this transsphenoidal surgery. In the past, it was microsurgery. Now we use an endoscope, transnasal endoscopic surgery. Sometimes we use a craniotomy. Third strategy for treatment can be radiation or radiosurgery, which often is not first line, but can be an adjunct, maybe in addition to either medical or surgical treatments. So, and again, this is just the trajectory of what we take from the nose into the pituitary. So some guidelines have been brought up. This is a paper by Dr. Vance, prominent endocrinologist at the University of Virginia, Dr. Post as well, one of my mentors, looking at what do you do for pituitary tumors that are just found accidentally because you hit your head or in a trauma and you got a scan of your head. And what they've recommended is that patients with an incidental loma, right, just an incidental mass tumor, pituitary tumor, that they be referred for surgery if they have a visual field deficit, so you have vision loss, if you have ophthalmoplegia or a neurologic deficit, your eyes aren't moving well, or neurologic compromise due to compression by a lesion, even a lesion abutting the optic nerve or chiasm. They found that those are tumors that should be removed because of the risk of losing your vision later on. Pituitary apoplexy, which is hemorrhaging into a tumor, visual disturbance, those should be referred for surgery. And if the incidental loma is hypersecreting, like we talked about Cushing's disease or acromegaly, for example, other than a prolactinoma, which should always be treated first medically. Here, Dr. Zada and among many other prominent surgeons and doctors, they've reviewed what is the consensus agreement on the management of patients with non-functioning, non-secreting pituitary adenomas. So they're they looked at this and they felt that at least exploring all the literature for symptomatic non-functioning pituitary adenomas, that surgical resection is recommended as the primary treatment for symptomatic patients with these types of tumors. Now, how about asymptomatic non-functioning pituitary adenomas? Again, non-secreting. They could not make a formal recommendation. And so these non-functioning adenomas, non-secreting adenomas, they exert they create problems because of mass effect. So they're not overproducing hormone, but they create mass effect because of all those structures we reviewed in the anatomy, right? They enlarge, they grow, and they can compress the optic nerves. They can stretch the dura and create headache. They can lead to hypopituitarism or a reduction of your normal pituitary hormones. They can even bleed. This is an example of a patient with a non-functioning pituitary adenoma before surgery. This is a look at their vision, their visual fields. And you can see there's a hole in their vision here and here. This is normal vision. After surgery, it's restored. You know, it's all green now. And that's after removing the pressure of that tumor off of the optic nerves to restore their vision. So what are the general outcomes of surgery, transfemoidal surgery for non-functioning adenomas? Visual improvement is dramatic and very successful at improving vision. Relief of headache also can be very successful. 95% of the time we can preserve normal pituitary function. Restoration of normal function is far more difficult. Sometimes the destruction of the normal pituitary gland by a tumor is irreversible. And so often you do require hormone replacement. Recurrence is about 16% in someone's lifetime. So how often do they come back in someone's lifetime? 16% of the time they can come back, but only 6% actually is symptomatic, where it grows enough to warrant further treatment. And a large number, more than 80%, live well after 10 years after someone's surgery. Now, acromegaly, and this is Dr. Laws, Dr. Vance, and they treated this gentleman here, who was a former NBA basketball player, for acromegaly. So acromegaly, we described earlier, it can also, these tumors, these growth hormone secreting tumors can also enlarge. So rather than just the growth hormone production that can ravage someone's body, the mass effect of the tumor itself can also lead to visual loss. You can also have hypopituitarism, apoplexy, or hemorrhaging, sudden hemorrhaging into the tumor. Symptoms we mentioned already before, but a couple of additions: increased sweating, increased size in the hands and feet, neuropathy, liver or heart failure, these colon polyps with increased risk of cancer, skin tags. All symptoms, certain irreversible conditions that can happen, liver and heart failure, which lead to increased mortality rate in these patients. This is the axis. This is how the hormones work. The hypothalamus, which is here, secretes growth hormone releasing hormone into the pituitary gland, and then growth hormones released by the gland goes to the liver, which stimulates it to produce IGF-1. And IGF-1 can go backward and actually negatively inhibit the release of growth hormone and growth hormone releasing hormone. And then there is this hormone here, or somatostatin, released by the hypothalamus, that inhibits the gland from producing growth hormone. So we can take advantage of this axis, this understanding of the hormonal patterns here medically. We can use somatostatin medications to orally or by injection to help inhibit the release of growth hormone. Sometimes that's a strategy that's used. Here's an example of an MRI, someone with a pituitary tumor here. Now, what are the outcomes? So after surgery, after transfemoidal surgery, again, mass effect, relief of mass effect, very high success rate of 95%. Improvement in the symptoms after taking out acromegaly, a growth hormone tumor. It depends. It depends on the location, but if it's not involving the cavernous sinus, which is the carotid artery space either side of the pituitary gland, then it's successful 95% of the time in improving acromegaly symptoms and signs. Normalizing the growth hormone, 50 to 72%. Preservation of the gland is high. Recurrence can be relatively low, less than 10%. Living it well, 10 years, 70% of the time. And prolactinomas is another form of hormone-secreting adenomas. Prolactin's released at the pituitary gland level. Dopamine, which is from the hypothalamus, is released into the pituitary to inhibit the prolactin level release. And prolactin stimulates glandular tissue in the breast for milk production. And so we can take advantage of this medically by giving patients dopamine agonists and oral medications, things like bromocriptine or ergoline, to help inhibit prolactin if there is a prolactinoma overproduction. Prolactinomas can lead to decreased sexual drive because prolactin in high levels diminish sex hormones, diminished erections in males, amenorrhea, loss of your periods or irregular periods in women, and challenges with becoming pregnant because of this, and galactorrhea, which is lactation, milky discharge from the breasts, or chest fullness. So, what are the indications for surgery? Again, dopamine agonists are the first-line treatment, and they're probably successful at least 70% of the time. So medical management is the best way to treat these first. Now, why go to surgery? Sometimes it has to happen because 30% of the time, the prolactinoma does not respond to the medication, so hyporesponsiveness. Intolerance of medical therapy. If patients don't tolerate the medicines well, they feel the bad side effects from it. Cystic adenomas, cystic tumors often don't get treated as well with the dopamine agonists versus solid tumors. CSF rhinorrhea, which this is CSF, cerebrospinal fluid leakage. It's normally surrounding the brain. Sometimes these tumors, they get treated medically, and so much so that a hole is created, and spinal fluid can leak out of the sella into the nose, and this needs to be surgically repaired. Apoplexy is another, again, hemorrhaging, sudden hemorrhaging into the tumor that can lead to headache and visual disturbance. Those are reasons why you may have to operate on a prolactinoma. For prolactinoma surgery, relief of mass effect, again, very highly successful with transsphenoidal surgery. Normalization of the prolactin can occur successfully anywhere from 50 to 87% of the time. Preservation of gland occurs often. Post-op fertility, because of normalization of the prolactin, thereby normalization of the sex hormones. This can improve at 87% of the time. And this is a picture of patients of Dr. Laws. Here, they're twins, and you can see the difference. At first glance, it may look subtle, but here, these twins, one of them has Cushing's disease, and you can tell this is the one probably with the Cushing's disease, has the rounded faces. You can see that here too. Cushing's disease, this can cause central obesity. So central obesity, there's this little hump here. They call this a quote-unquote buffalo hump. It's a fat accumulation just below the nape of your neck. They can also have fat accumulation at the clavicles or just above the clavicles. abdominal stria. These are bruising. Patients with Cushing's disease and high levels of cortisol can bruise easily. They don't heal as well. And then there's this association with cerebral atrophy, where Cushing's disease can create sometimes even a dementia-like picture, where the brain is more atrophied, not as full. So this is an MRI that we're looking at here, and this is the left hemisphere and the right hemisphere, and you can see these are deep valleys of brain loss, these holes that we call atrophy, that is higher in patients with Cushing's than others. Symptoms with Cushing's disease, hypertension. So one of the clues for someone potentially having Cushing's disease is you get refractory hypertension and high blood pressure. If you have someone young with high blood pressure requiring 3 medications, they've gone through all the tests for high blood pressure and nothing can be found, this may be a sign of Cushing's disease. Refractory diabetes, again, also in the young, Cushing's may be a factor here. Osteoporosis, again, the high levels of cortisol really ravages the body, makes the bones a lot weaker, so you can get multiple fractures. Obesity, we mentioned, ruddiness around the faces, the buffalo hump, you can get frequent infections. This axis here, again, the hypothalamus releases corticotropin-releasing hormone, which then stimulates the pituitary gland to release ACTH, adrenocorticotrophic hormone, which then stimulates the adrenal glands, which lie right over your kidneys, to produce cortisol. And so a tumor at this level overproducing ACTH will overproduce cortisol in the bloodstream. Excuse me. The diagnosis for Cushing's disease, you have elevated corticosteroids with loss of the variation that you have over the course of the day. So we can detect this by checking saliva, the urine, we check serum, ACTH, we check tests called dexamethasone suppression test, and sometimes we have to go do invasive testing and actually sample blood on either side of the pituitary gland to check the ACTH levels. It's a very challenging disorder to diagnose. And this is just an example of the sinus sampling test that's done in some centers. So indications for surgery for Cushing's disease, the gold standard, if possible, is really surgical to remove the actual tumor. In patients that have multiple medical problems, are very sick, could not tolerate a surgery, or if their tumor is too large and or invading these cavernous sinus areas, then medical management or radiation may be a better option. Other reasons for surgery may be because they're so big, they're pushing on the optic nerves and they need to decompress it. So Cushing's syndrome is, so this idea of Cushing's disease, this is actually coming from the pituitary gland, but you can have the same form of disease and elevation of ACTH and thereby cortisol by other tumors, adrenal adenomas, which are far less common. There are adrenal carcinomas that can overproduce ACTH and then cortisol, or you can have a source. Different cancers can actually produce ACTH and cause Cushing's. But most often Cushing's is Cushing's disease and comes from the pituitary gland. Outcomes, again, mass effect relief is very high after transsphenoidal surgery. Normalization of ACTH depends, again, anatomically, whether the tumor is very large, whether it's invading the cavernous sinus, that can be as high as 91%. Preservation of gland function is very high, 95%. Recurrence at about 12% in 10 years, and the vast majority of the patients live well after surgery. I'm going to pass this here. And just to briefly, excuse me, just go over, I'm not going to go through this entire slide here, but I'll say that the evolution of surgery for pituitary tumors goes as far back as 1806. And over the centuries, there has been a lot of advances from very innovative surgeons. Victor Horsley, in the past, craniotomy, drilling a hole above the ear, behind the eye, to get to these tumors was really the only way to remove pituitary adenomas. And then through the nose, making incisions through the nose, going through the mouth. Harvey Cushing, one of the founding fathers of neurosurgery, explored that approach. And then going through the nose became popularized. Hirsch was one of the first that looked at that. And then there were different imaging strategies using technologies, using fluoroscopy, KEO in 1958, X-ray guidance to help get through the nose, and even under the lip. Here, this is under the lip, sublabial approach to get to the tumor. Above the hard palate to get to this approach into the sinus and into the gland. And it's in the mid-1900s, 1960s, we have the advent of endoscopes. Hardy, very prominent neurosurgeon, really did fantastic work with pituitary surgery. He used the microscope. You can see in this picture, the surgeon has a microscope which is outside the patient's face, and looking through these oculars, magnifying multiple times through the nose or under the lip in order to look at this, in order to visualize the tumor. And that's microscopic, that's transsphenoidal microscopic surgery that Hardy was performing. And then in the mid-90s is when this explosion of endoscopic, endonasal transsphenoidal technique was starting and being popularized. Dr. Joe, Dr. Corral, Capabianca, these are all prominent surgeons to really build this idea of endoscopic surgery. And now using a camera that looks like a pen through the nose rather than big incisions or a microscope outside the face. And it's just interesting how this brain hook here, this idea of approaching the brain through the nose is even further back than the 1800s, and back in Egyptian times when the embalmers would, ancient Egyptians would remove brain matter through the nose using a long hook that looks like this, so that they knew that this was possible. And then till now, when we look at these different approaches, a sublabial approach to get to the nose and to the tumor, transseptal approach where we go through the septum, through the nose, a microscope, and now what we're doing, endonasal, endoscopic, going through the nostril itself with a camera that looks like a pen, this endoscope technique. This is a view of what I was showing earlier of Dr. Hardy in his color illustration. This is a speculum inside the nose. The microscope is outside the patient's face and magnified deep through the nostril, and here's the tumor. So the view is, visualization is poor compared to what we can do now, which is this approach. This is a picture from earlier, where we can place the camera and the lens is exactly on the pituitary gland or any anatomical structures that we're looking at. So this is the endoscopic approach. Panoramic, the lighting is much better than the previous approach. We have technology now that we use in the operating room to help guide us. The operating room setup. This is a picture from Dr. Dan Kelly and Parkadarian's setup, how they, over at Pacific Neuroscience Institute now, their setup is a lot more complicated now. Lots of equipment, lots of different technology to help make surgery quicker and safer. And so, as Dr. Oyasiku over in Atlanta, but this the setup we have now. It's two surgeons typically, a neurosurgeon and a sinus sculpey surgeon, one holding the camera, the neurosurgeon using both hands to remove the tumor. And now the evolution of pituitary surgery has really evolved to the point where we can now not only get pituitary tumors out through the nose, but we can get several other tumors elsewhere. Do the same approach. So I'm going to wrap up here with just this idea now of this center of excellence, which many prominent pituitary surgeons across the world and prominent endocrinologists have come up with. And this idea of a center of excellence for pituitary disease comes from the complexity that it brings. That's the anatomy we discussed, the diagnosis, the management, and this really warrants a multidisciplinary approach for best care. So we need multiple specialties that work together well, that work together often, that see these disorders often. And so this idea tries to bring together a cohesive team of specialists who promote collaboration, apply best practices in a specific focus, your pituitary disease, to improve results and overall outcomes. And that's been clearly found in bariatric surgery, where they require multiple disciplines: general surgeons, psychiatrists, nutritionists, and different therapists to come together to decide on the best strategy for patients and who would be the best candidate for bariatric surgery. So there is a precedent for this idea of center of excellence. It's clear that complications are higher among those centers and surgeons that don't operate as often and do transfemoidal surgery as often. This goes for surgery for acromegaly as well, where this center here, they found that their outcomes for cure of acromegaly was lower than when a single surgeon performed it in a higher volume, less complications, higher success rate, and higher rate of cure. Someone that was dedicated to that surgery. So this idea, this pituitary center was looked at very recently. This Pituitary Society put out a position statement about the criteria for the definition of the pituitary tumor center. And again, it just all surrounds this idea of having a specialized endocrinologist or gists or a neurosurgeon or neurosurgeons that are focused on pituitary disease with neuroradiologists, neuropathologists, radiation oncologists, and neuro-ophthalmologists, all in this close-knit circle here where other external endocrine units, other community endocrinologists that are often the referring doctors that see patients initially can send to this pituitary center of excellence to improve care of excellence for pituitary tumor patients. So, yeah, we do this also at Loma Linda University. And I just move forward here, and we are losing time here, but I'm going to just wrap it up now. These were examples of cases here. Just give me a moment. That I think maybe we can share another time. But what I wanted to conclude with was basically just understanding that the pituitary tumor diagnosis, management, treatment is complex. And it's important that the detection is as early as possible, because problems that patients can face with visual loss, with Cushing's disease, with acromegaly, these are reversible problems. Okay, these are curable problems, and so we never want to have a delay so much that these problems become irreversible. So I just wanted to thank everyone here. Let me get back here, sorry. Yeah, so like I mentioned here, I think patients with pituitary disease can benefit from earlier recognition by primary care doctors, family physicians, optometrists, ophthalmologists, and looking at those kind of classic Cushingoid symptoms, those classic acromegaly features, someone with visual field deficits, maybe after evaluating them for other conditions like glaucoma, maybe getting an earlier MRI of the brain to help detect these pituitary tumors may be helpful. Again, earlier recognition does lead to improved outcome. And surgical management in high volume centers and by high volume surgeons does lead to better outcomes. Yeah, these are some of the references that I used during this talk. Again, I want to thank Dr. Laws for his several of his slides that he allowed me to use. And this is my email address if anyone needs to contact me. I think, through the Pituitary Network Association, you can find me if you like. I can always answer any questions anytime. I just wanted to wish everyone happy holidays, happy New Year. Thank you, particularly to Tammy and the Pituitary Network Association. This is an incredible association that's doing fantastic work for a very prevalent, very common problem, and I really applaud their work. I thank you for allowing me to speak, and I hope this was helpful. Thank you.
Very helpful. Thank you so much. Excellent presentation. We appreciate you taking the time out to do this so that everybody can get this information. We do have a few questions. First question is, this person had a pituitary tumor removed by craniotomy and then radiation afterwards. Is it possible to grow another one?
Yes, so, radiation is very helpful in controlling pituitary tumor disease. It's actually been shown to be very successful at lowering the rate of recurrence and it coming back. But it's not 100%. It does depend too on the size of what was left behind, the residual that was left behind, and what the amount that was actually radiated. Sometimes tumors that are up against the optic nerves, for example, or the brainstem, these are very sensitive structures that can sometimes limit the amount of radiation that can be delivered. Overall, radiation is probably at least 95% successful at preventing recurrence. So highly successful. Again, dependent on some of those factors I just mentioned, it depends a little bit. But I would imagine that the chances of that occurring or recurring are low. But always remember that you will forever need surveillance imaging and probably MRI imaging to make sure that that tumor that's left that was radiated does not come back. And sometimes, even though it may grow a little bit, it may never require any more treatment. It may just grow a little, never cause you symptoms, and may stagnate eventually. So I think, radiation has a very strong role in the management of these tumors.
Okay, thank you. After seeing various doctors over the years, my pituitary tumor was finally discovered. How long is the average amount of time a pituitary prolactin tumor is growing before it is finally medically diagnosed properly?
Well, I think prolactinomas, compared to growth hormone secreting tumors and ACTH tumors and acromegaly and Cushing's, prolactinomas seem to be detected far earlier. So they're often detected as microadenomas, tiny little tumors, and then they're often found in younger women, and I think that are more cognizant of some symptoms like their period. So if your menstrual cycle gets affected and is not regular, what often happens is an OBGYN will start the process of exploring why that's happening, order a prolactin level, and that can lead to detection pretty early. So I think overall, I don't have a number of years or timing, but I think overall the symptoms of a prolactinoma, this irregular periods, the galactorrhea, the lactation, those things are a very quick trigger to getting tested faster and getting an MRI imaging faster. So yeah, I don't know if that answered the question. But.
Okay. If one has normal prolactin level with nipple discharge, everything else being normal, should doctor still test for pituitary tumor?
You know, I've come across patients with exactly that. I actually once had a male patient that had discharge and was sent to me because there was an assumption that this was a prolactinoma. So I think by definition, if your prolactin level is normal, then you don't have a prolactinoma. And I would explore other reasons such as gland hyperplasia. Maybe the glands in the breast are enlarged, or you have cysts in the breast that may need to be looked at with ultrasound or other imaging modalities of the breast, or potentially even biopsy sometimes of tissue in the breast. So if your prolactin levels are normal, and sometimes you may want to have them repeat that level to just confirm that it really is normal on 2 different occasions, then I don't think getting an MRI of the brain is really warranted.
Okay, thank you. Is there an inherited risk for pituitary adenomas? For example, I had non-functioning adenomas and wonder if my children are at risk.
So yeah, I often get that question too. The pituitary tumors, again, are mostly, the vast majority of them, I'd say probably 99% of them, occur just randomly, just spontaneously, without any rhyme or reason. The only ones that can be hereditary, that can be passed on from generation to generation, are in patients with conditions called multiple endocrine neoplasia, MEN, which is a condition where multiple glands in your body, your pancreas, your parathyroids, and your neck gland, also have tumors. So, and those are tumors that can be detected with other blood tests. Pancreas blood tests, there are parathyroid calcium tests that can be looked at. And if you have other tumors in those glands and a pituitary, then you may want to get genetic testing for MEN, multiple endocrine neoplasia. And if that comes back positive, then you may want to have family members, direct family members looked at. But again, the vast majority of them are spontaneous, random, and no need to worry about passing them along or having other family members checked.
Okay, thank you. Can pituitary tumors cause high cholesterol?
Can pituitary tumors cause high cholesterol? That's a really good question. You know, we come across multiple medical conditions. We always wonder, is it connected to the pituitary, because the pituitary gland is so integral to all the activities in the body. I have not seen that connection though. I have seen hypertension and high blood pressure improve after pituitary tumor surgery. That's a little bit unclear too why that happens. Although in patients with Cushing's disease who inherently have hypertension because of their cortisol levels, taking out a tumor like that should improve their blood pressure. But even in patients without Cushing's disease, there has been some anecdotal information among pituitary surgeons, including myself, that have found high blood pressure improve, and that's something I actually want to look at and study more. But cholesterol, I have not seen any relationship with the pituitary gland or pituitary tumors, though.
Okay, thank you. Next one, thank you for all this helpful information. My husband had a macroadenoma, 2.8 centimeters, which was removed via transsphenoidal surgery. He was left without his pituitary gland and transhypopituitarism. His peripheral vision was not restored, however, frontal vision was restored. We're still struggling with managing his meds overall. Do you have any suggestions?
Yeah, that can be challenging, and thanks for the question. Hypopituitarism, requiring full hormone replacement, which sounds like your husband is requiring now, it can be very challenging. What I would suggest, and maybe I don't know who his endocrinologist is, but it does require a specialized endocrinologist. Most endocrinologists will manage the very, very common disorders of diabetes, for example, and thyroid conditions. There are a few endocrinologists that specialize in pituitary disease. So again, I don't know who yours is, but I have had patients that have gone through similar situations like your husband, and it's a long battle, it's a long struggle of for example, hypercortisone. How is it too high? Is it too low? The desmopressin medication, sometimes the fluid balance is not quite right. It can take sometimes a year, if not years, before the right balance of meds can be found. So it may require a very subspecialized endocrinologist to help manage that. It may also require just time. And I tell my patients too that if that happens, the expectations have to be that it'll take time. But I am confident that there will be that right balance, because I've seen it time and again. The challenges of it, no doubt, very difficult, can be very depressing too. Having to go through all these medication changes and not getting the right balance, but it'll happen. It for sure will happen.
Excellent, thank you. I don't see any more questions. I think based on that last question, what you mentioned earlier about centers of excellence or multidisciplinary teams, I think that would be a big help in a situation like that, is going to obviously a specialist or even a multidisciplinary team to find expert help. Oh, and I do have another question here. At 41, had a transfemoral surgery of a NFA cystic adenoma in 1997. Needed only testosterone replacement post-surgery. In 2005, MRI showed a very, very small regrowth, asymptomatic, advised to just watch. 2008, awoke with severe headache while living in Poland working for NATO. Could not focus visually on high-resolution computer screen. Upon closing left eye, the headache would subside, but vision very impaired in left eye. Found that the small regrowth of the adenoma in 2005 was now a macroadenoma. Flying home, apoplexy, and then had surgery. Oh, they're still commenting. Huh. Any suggestions for something along those lines? And no functioning of gland. They're still typing information in.
Apoplexy, no gland function.
Right.
And the patient did end up.
Oh, okay. And then the gland was totally destroyed by surgery.
Okay.
Then had cyberknife. Twice. Are you on hormone replacement? On all hormone replacements. Any suggestions? Oh, any good endocrinologist? I would say you definitely need a pituitary specialist. Oh, in Lafayette, Louisiana. I would have to research that and get back to you. Dr. De Los Reyes, do you know of any in Houston, Texas?
Oh, I don't.
I think there's a couple of pituitary centers in Houston. I can get back with you on that and send you an email. I can't look them up right now. But when I can, I'll definitely send you an email with some information.
I think when you mentioned, Tammy, about that, yeah, just finding that right pituitary center, it's just, it's so important. And that I'm glad you reiterated that, because you can't take it for granted. I think it just makes sense. You know, the higher the volume endocrinologists see with patients with that exact thing, and hypopituitarism requiring 5-6 hormones to replace, or the surgeon that sees those more often and operates on them more often. I think it's key to find that. And I think, I mean, in the Pituitary Network Association page, it's nice to you have that whole catalog, I guess, of doctors and specialists that you can find all across the country, if not the world, I think, right?
Right, yes, definitely. You know, there are quite a few of them on our list. Another suggestion would be, coming from another commenter, was for a neuroendocrinologist, which I will get some information to you on all of that. Another question. I have a 1.2 centimeter pituitary adenoma that has been followed for 10 years with MRI with no growth since found. Is it okay to stop MRI now? That's a good question.
That's a really good question. Yeah. You know, I would say, well, one thing I'll mention too, I think there is, and I get this from other patients, what's the risk of MRI, for example? If I get MRIs every year for the rest of my life, am I at risk for something? So I just want to mention that, because MRI is magnetic, right? It's a magnet. So the MRI itself does not harm you. There's no cumulative effect of getting multiple MRIs like there is for CT scans, or which is a CT scan has radiation, and so there is a cumulative effect for CT scans over your lifetime. And MRI, not so much. Getting contrast with the MRI too, you know, the known risk of contrast is in patients that have kidney failure. There is no evidence that contrast, they usually use gadolinium for an MRI, poses any risk to you. So that's, I just want to mention that. So in terms of, do you have to get MRIs for the rest of your life after 10 years of stability? So I think that's great news for you. You are in the group of patients with pituitary tumors that is just stagnating. So that sounds like you'll be in good shape. But I would not let it go, though. I think I would probably, I don't know how old you are, but generally I try to, if I saw someone with a pituitary tumor, incidentally, I would get one at around that size once a year, and then probably once for about 5 years, and then every 2 years for another 5 times, and then every 5 years or so. So I don't think you would have to. I don't think you have to get it every year at this point. But in the end, I think you have to get it every few years still. And you know, that may also depend on whether at 1.2 centimeters, I don't know if it's up against your optic chiasm or optic nerves, because if it is, you also probably want to see an ophthalmologist regularly too, to make sure that they don't that they can detect any subtle vision change that may require, or you may benefit from treatment at that point. So I wouldn't let it go. I do think, there's surveillance. If you get you need to get a colonoscopy every 10 years, for example, after the age, I don't know what it is now, but at least after the age 50. So, or mammograms they suggest for surveillance. So this is part of your, I think, surveillance, whether it be an MRI, and then seeing the ophthalmologist if that tumor is pushing up on or against the optic nerve.
Excellent. Yeah, she did comment that the optic nerve is clear at this time, and she still does get visual field tests, which is great. Another question: what are long-term effects of CyberKnife therapy post-surgery?
Yeah, so that's interesting. CyberKnife, again, this idea of radiation or radiosurgery. CyberKnife is just a brand name. Gamma Knife is another brand name for radiosurgery, and it's focused radiation, targeted at high doses of radiation targeted to a specific area. So, what are the side effects? So, I don't know if you have any needs for hormone replacement, but it has been shown with radiosurgery. Probably it kind of some different numbers, but probably at least 50% of patients that undergo CyberKnife or Gamma Knife or radiosurgery, radiation to their pituitary tumor, if they don't have pituitary dysfunction already, will have pituitary dysfunction in their lifetime. So about 50% of people with pituitary tumors that get radiation will have pituitary deficiencies at least 10 years from now, and that will require hormone replacement. So something important to remember. Any other downstream effects of radiation? There have been reports of other tumors developing from radiation. That's decades from now. Usually not something that you would ever experience in the next 10 years, but there have been reports of things like tumors developing in the path of where the radiation goes into the pituitary of developing. That's a small risk. And then any radiation can, they try to limit the radiation affects the normal surrounding brain or nerves, but you can develop nerve dysfunction, like double vision, for example, or your optic nerves can be affected years from now because of some small effects that the radiation may have caused. So, those are some examples that can, some things that can happen that are unlikely but are possible.
Okay. Couple more questions. She had a macroadenoma, and her surgery had to be done in 2 parts. It was close to the optic chiasm. Is it common practice to go in twice for a macro?
Is that through the same approach?
I don't know.
Because
yes, the same approach.
I'm just trying to understand. Is it back to back, or is it? Like,
oh no, it was October 2008 and March 2009, so it was close together.
Okay. Well, it depends. I think, you of course plan on trying to get tumor out the first time around. Sometimes one strategy that some surgeons use will be going through the nose transsphenoidally, taking out tumor that they can safely take out, and sometimes the tumor is so big that they can't get it all, and they wait a certain amount of time for the tumor. Sometimes the tumor is so high up in the brain they can't reach it through the nose. So they'll take the bottom half of the tumor, and then months, maybe a year later, they are hopeful that the tumor descends and comes down into the nose more, just with gravity, and a second transsphenoidal surgery through the nose to take that descended portion could be done. You know, I don't know if that's one possibility. You know, other times, you know, you take out tumor through the nose endonasally, and the tumor recurs very quickly. Whatever was left behind the first time grows faster, and you have to do a second surgery. I haven't seen that happen because pituitary tumors are so benign and slow growing. They often don't grow that quickly. So it's not out of the realm of possibilities that repeat transsphenoidal surgeries in a year's span is done. I have had to do surgeries, repeat transsphenoidal surgeries through the nose because of inadequate resection the first time around. And so I will try to use, maybe do a bigger opening through the nose and use some other techniques to take out more tumor because it was inadequately removed the first time around. But so that's possible. And sometimes, you know, years may pass, and if the tumor, you know, regrows after, you know, 10 years, that definitely happens, and that can require a second transsphenoidal surgery. That second time around, though, is a little more challenging. You know, going through the same approach, you would think would be easier because the opening is there already deep in the nose, but there's a lot of scar where the tumor was, where the pituitary gland is, so it can be definitely more challenging.
Okay, thank you. Next question. How often should a microadenoma, last noted to be 3 millimeters, be monitored by MRI? What labs should be ordered, and how often for monitoring? PCP refused referral to specialist. And then another question from the same person. Are microadenomas ever associated with nausea and CFS leaks? This is an anterior microadenoma.
Okay, so for a microadenoma 3 millimeters, that does sound small. The first step, whether it's your primary care doctor or whether they refer to an endocrinologist, is to order a full set of endocrine labs. So every hormone that your pituitary gland produces, which includes you know, FSH, LH, which are the sex hormones, growth hormone, and IGF-1, which are the growth hormones, ACTH and cortisol, the prolactin, a basic chemistry, thyroid hormone. So these are all the hormones that the pituitary gland produces. You can ask your doctor to order, and they should know to order, to make sure that this small 3 millimeter microadenoma, to see if it is overproducing hormone causing Cushing's disease or acromegaly, or if it's causing a reduction in your hormone because it's pressing up on your pituitary glands. So that's important. That full set of, in many places, many labs, they call it the endocrine panel. It's a full set of blood tests. Now, how often do you have to get imaged for this? I was mentioning earlier, when I have a patient come to me with a newly diagnosed tumor, if there is no plans for surgery, a newly diagnosed one, I would get one once a year for at least 5 years, because what I want to see is I want proof that your little 3 millimeter microadenoma is acting like it should, which is basically either grow very little or not grow at all in a 5-year span. And if it doesn't grow every year for about 5 years, then I would start saying every 2 years a few times, and then every 5 years or so. Now, a microadenoma causing a CSF leak, at that size, it's very, very unlikely. I have never seen it. I don't think that's really been reported. So I would not I wouldn't be worried about a CSF leak. Leaving it alone, a 3 millimeter microadenoma left alone, it won't by itself create a CSF leak, no. Surgery may, sometimes for prolactinomas, we treat them with medication and they melt away, and then CSF leaks because of a treatment effect. But tumor, 3 millimeters, don't do anything for it. CSF leak is not going to happen.
Okay, thank you. We are way over our time, so I think there are still some questions. Maybe we can possibly answer those by email. I want to give everybody a chance to enjoy the rest of their day. This concludes our presentation. We appreciate you taking the time to join us. If we did not get a chance to answer your questions, like I said, there are a few more. We'll be answering them by email. If you missed any part of this webinar, or if you would like to share it with friends or family members, we are going to be posting it on our website at www.pituitary.org. Give me a chance to get it edited and posted, and then it will be available, like I said, on our homepage. We, again, appreciate everybody. There's going to be a brief survey after the webinar. Fill it out to help us get you the information that you need. Somebody just asked if the slides will be there. Dr. De Los Reyes, if you could provide your slides, we'll include that as well.
Absolutely, yeah.
We really appreciate you taking the time, Dr. De Los Reyes. Excellent presentation. Thank you all who have stuck it out for this extended period of time. Again, everybody have a great day, and we'll see you on the next webinar. Thank you.
Thank you, Tammy. Thank you all. Bye.
Bye.